The main rationale for transplanting fetuses before birth instead of waiting until after birth is because fetuses can be educated to tolerate new kinds of cells before birth. And one of the beauties of using maternal stem cells is that the fetuses should already be tolerant to those maternal stem cells because of trafficking between the mother and the fetus before birth. Now, you can do a hematopoietic stem cell transplant after birth, but there are several issues that arise with those transplants. One can be, it's that it can be hard to find a suitable donor. But before birth, fetuses are tolerant to their mothers, so the maternal donor can be used. The second is that the medicines that you give to prepare the patient's bone marrow for the transplant can be pretty toxic, whereas before birth, we don't need to give any medications to prepare the bone marrow for the transplant. So this is a phase 1 clinical trial. So we're really looking at the safety and feasibility of doing these stem cells before birth using the mother's bone marrow. And the good thing is that we did not see any safety events in the 2 patients that we've transplanted. The trial is ongoing, but we thought it would be important to present the results of our first 2 patients so that we can inform collaborators about the safety and feasibility of this protocol. So both patients tolerated the maternal bone marrow harvest very well, and both fetuses tolerated the stem cell infusion very well. The transplant that's done before birth is not meant to be curative completely of the disease. The main thing that we're hoping for is for the patient to continue to be tolerant to the mother so that we can do a second booster transplant after birth using the mother's cells. And that second booster transplant can be done with a very much lower dose of immunosuppression compared to if the patient had never had a fetal transplant. So we did see that in the first patient who was transplanted a little bit earlier with a higher dose of cells, that patient continued to have tolerance to the mom for the entire first year after birth, which was very encouraging in that we should be able to do a booster transplant, although we have not performed that in that patient. The other thing I should add is that patients with alpha thalassemia major often die before birth. And our protocol is showing that as long as we do serial transfusions before birth, it's possible to survive the pregnancy, to be born at term, and to have good neurological outcomes, which gives us further options for being able to take care of these pregnancies. I think in utero stem cell transplantation is a really exciting area for clinical research. We and others have shown in animal models that you can transplant stem cells into the fetus and have meaningful levels of engraftment, and that even if you don't have high levels of engraftment, if you're simply tolerant to the stem cell donor, you should be able to do a booster transplant after birth. So in addition to alpha thalassemia, this protocol can be useful for fetuses with many other blood disorders, such as beta thalassemia, sickle cell disease, or Fanconi's anemia. And we're hoping that once we show the safety of this protocol in a disease where the fetuses already need to have a procedure, that we should be able to expand the protocol for fetuses with other common disorders such as sickle cell disease.